Welcome, everyone. Today, we're going to step into the clinic and solve a diagnostic puzzle. We're going to build a really systematic, university-level framework for how to approach bleeding disorders, essentially turning what can be a really complex clinical picture into a clear, logical diagnostic path. Okay, so here's our roadmap for today. We'll kick things off with the most fundamental question a clinician has to ask. Then, we'll work our way through the diagnostic funnel for low platelets. From there, we'll explore what happens when platelets are present but just don't work right. We'll dissect the complexities of von Willebrand disease, learn how to decode coagulation tests, and wrap up by tackling the systemic chaos that is DIC. You know, every investigation, every workup, it always starts with one single pivotal first step. And in hemostasis, that step is all about characterizing the nature of the bleed itself. This is the absolute foundation that the entire diagnostic structure gets built on. So let's look at our first case. We've got a young patient, recurrent gum bleeding, and a platelet count that is critically low, 17,000. But the standard coagulation studies, the PT and APTT, they come back normal. Now, this very specific set of clues points us in a pretty clear direction, but our first analytical move here is absolutely crucial. And this table right here illustrates that first step perfectly. The key question is this: are we looking at a platelet-type bleed or a coagulation-type bleed? See, platelet problems show up right away, immediately, at mucosal and superficial sites. We're talking gum bleeds, nosebleeds, or those little pinpoint skin hemorrhages called petechiae. On the other hand, coagulation factor defects, they present with delayed, deep tissue bleeds, like bleeding into joints, that's hemarthrosis, or big, single bruises. Our patient's gum bleeding, that fits squarely in the platelet-type category. So now that we have identified a platelet-type bleed, and we know the platelet count is low, that's thrombocytopenia, our next job is to figure out why. We don't do this by jumping to conclusions. Instead, we have to move through a really rigorous, systematic funnel of exclusion. And this right here is our diagnostic funnel. We've actually already done step 1. We know it's a platelet-type bleed. So step 2, is this an isolated platelet problem, a single lineage issue? Or are the red and white cells also low, suggesting a bigger trilineage problem in the bone marrow? In our case, it's single lineage. So now we can move on to 3 critical exclusionary steps to really pinpoint the cause. Let's just zoom in on step 3 for a second, ruling out drugs. This is a huge one, because medications are an incredibly common cause of low platelets. And they can do it through a few different mechanisms, from triggering autoantibodies like we see with procainamide, to forming immune complexes, which is the classic mechanism for heparin-induced thrombocytopenia. You can even have a drug-specific antibody, which we see with a drug like abciximab, that can cause platelets to just plummet in under 24 hours. So after we've gone through our whole funnel, we've confirmed it's a single lineage issue, we've ruled out any offending drugs, we've excluded sequestration of platelets in an enlarged spleen, and we've checked the peripheral blood smear to make sure there are no fragmented red cells, or schistocytes, which would point to something like TTP. We finally arrive at a diagnosis of exclusion. When all 5 of these criteria are met, only then can we confidently diagnose immune thrombocytopenia, or ITP. So what exactly is ITP? Well, it's an autoimmune process where IgG antibodies basically tag platelets for destruction. And on top of that, they also mess with their release from the megakaryocytes in the bone marrow. Now, it's really important to remember that we're talking about primary ITP here. We always have to rule out secondary causes first, with the most common ones being SLE, as well as HIV, HCV, and even H. pylori infection. Now, when it comes to therapy for ITP, the goal is not necessarily a cure. What we're really aiming for is a safe platelet count to prevent a major bleed. And the decision to treat or just observe hinges on a really critical threshold. If the count is over 30,000 and the patient is doing fine with no symptoms, we typically just watch and wait. But if that count drops below 30,000, we step in and treat, and that's regardless of whether they're actively bleeding, because the risk of a serious hemorrhage is just too high. Our therapeutic approach is really stepwise. First-line therapy is almost always corticosteroids. Now, in really severe cases, say a bad bleed or a count below 10,000, we'll add IVIG or anti-D to get that platelet count up fast. The thing is, up to 75% of adults might relapse, so that's where our second-line therapies like rituximab, TPO agonists that boost platelet production, or even splenectomy come into play. All right, let's pivot to a new puzzle. What happens when the quantity of platelets is totally normal, but the patient still has a severe platelet-type bleed? This is what points us away from a quantitative problem and straight towards a qualitative or functional defect. Okay, so here's our second case, severe mucosal bleeding. classic for a platelet issue. But look at her platelet count, 120,000, well within the normal range. This mismatch, this discordance between the clinical picture and the lab numbers, that is the absolute cardinal sign of a qualitative platelet disorder. These inherited functional defects, they really fall into three main buckets. You've got adhesion defects like Bernard-Soulier syndrome, which is a problem with the GP1b9 receptor. Then there are aggregation defects like Glanzmann's thrombasthenia, which is caused by a faulty GP2b3A receptor. And finally, you have granulation defects, which affect the storage and release of critical molecules from what are called alpha or delta granules. So, the diagnostic pathway for these disorders is a multi-step process. The old, outdated bleeding time test has been replaced by something called the PFA 100. It's a modern screening tool that tells us how long it takes for a clot to form. If that time is prolonged, it suggests a functional defect. The next step is the ristocetin test, which specifically looks at adhesion, and that's followed by the gold standard, platelet aggregamometry, which gives us the definitive characterization. Now, the ristocetin agglutination test, or RET, acts as a critical fork in our diagnostic road. A negative result, meaning the platelets don't clump together, points directly to an adhesion defect. That immediately narrows our differential diagnosis down to just two possibilities: Bernard-Soulier syndrome or von Willebrand disease. On the flip side, a positive result tells us that adhesion is fine, which directs our investigation towards potential aggregation or granule defects instead. So let's dive a little deeper into one of those key differentials for a negative RAT. Von Willebrand disease is by far the most common inherited bleeding disorder, and it's this fascinating spectrum of disease that really sits at the crossroads of platelet function and the coagulation cascade. And this slide brilliantly illustrates why it's so unique. Von Willebrand factor basically has two main jobs. First, it's like the molecular glue for platelet adhesion. It connects platelets to the injured blood vessel wall. Second, it acts as a bodyguard, or a chaperone, for factor VIII, protecting it from being cleared from the blood too quickly. This dual role is why a deficiency in VWF can present with features of both platelet type and coagulation type bleeds. The classification system really reflects this complexity. Type 1 is the most common. It's a partial quantitative defect that causes mild platelet-type bleeds. Type 3 is a complete absence of the factor, leading to severe combined bleeding. And the Type 2 variants are all qualitative defects. 2A is missing the most effective high molecular weight multimers. 2B is a gain-of-function mutation that causes platelets to bind spontaneously, which can lead to thrombocytopenia. And 2N is really fascinating. It can't bind to factor VIII, so it actually mimics hemophilia. Okay, let's try to synthesize what we've learned so far and apply it to interpreting the most common lab tests we run for hemostasis, the PT and the APTT. It's really all about recognizing the patterns. So here's a classic scenario you'll see all the time. The prothrombin time, or PT, is totally normal, but the activated partial thromboplastin time, the APTT, is prolonged. What does this specific pattern tell us about the potential underlying defect? Well, this is where the clinical context is absolutely everything. If you have an isolated prolonged APTT, but the person has absolutely no history of bleeding, it strongly suggests a factor XII deficiency, which is clinically benign. If there's mild bleeding, it might point to a factor excise deficiency. But if there is severe bleeding, now we're thinking about the hemophilias, factor VIII or IX deficiency, or even certain types of von Willebrand disease where that factor VIII carrier function is messed up. All right, for our final section, we're going to move from these localized, specific defects to a full-blown systemic catastrophe. Disseminated intravascular coagulation, or DIC, isn't really a primary disease itself, but rather a devastating syndrome where the entire hemostatic system becomes pathologically activated. At its absolute core, DIC is defined by one thing: uncontrolled systemic thrombin generation. The trigger is usually a massive release of tissue factor, often from something like sepsis, major trauma, or certain cancers. This just ignites the coagulation cascade everywhere at once, leading to widespread clots in the small blood vessels. And critically, this process just chews through all the available platelets and factors, which then leads to a catastrophic failure of hemostasis and, paradoxically, severe bleeding. The lab results really tell the story of this consumption and the breakdown that follows. Platelets and fibrinogen are low because they're being used up to make all these clots. The PT and APTT are prolonged because all the clotting factors are being consumed too. And then, as the body desperately tries to break down all these clots, you see fibrin degradation products and D-dimer levels just skyrocket, reflecting this massive systemic fibrinolysis. And so we end with the question that really gets to the central paradox of DIC. It's a pretty stark reminder of the exquisitely delicate balance of our hemostatic system, a system where a single massive insult can push the scales so far that the body's mechanisms to stop bleeding and the mechanisms that cause bleeding start happening all at once everywhere.